So good evening, everybody. And at the outset, I thank the organizers for inviting me in this August podium. And also, I would like to thank all my respected audience. So I start today's discussion with this MR image of the pituitary. So this is the MR imaging of the pituitary of a 24-year-old female who was referred for endocrine consultation on the first post-operative day after pituitary surgery. So this was the MR imaging pre-operative. Now, what was the reason? That the patient had diabetes insipidus and her sodium level was rising on the day one post-operative. That's why the endocrinologist was consulted. Now, while evaluating a preoperative hormonal profile, it was found that the patient had a TSH of greater than 100. In the post-operative hormonal evaluation, which was performed at 6 weeks, revealed a free T4 of 13.8 picomole per liter, which was more or less normal, and all the other hormonal parameters were also within the normal range. And the girl resumed her normal menstrual periods in the next 3 months post-operative. So what we find is the girl did not have obvious symptoms or signs or hormonal profile depicting multiple pituitary hormonal deficiencies, which might be common in any pituitary surgery, irrespective of age, in cases of pituitary macroadenomas. So, with taking this case in the context, our girl, the 24-year-old female, was in fact lucky that she did not have any deficiencies, post-operative permanent hormonal deficiencies as far as the pituitary is concerned. So in this context, we describe the dome sign, and we will try to find out if it can be a radiological cornerstone to prevent unnecessary pituitary surgeries. So talking of unnecessary pituitary surgeries, I will go directly into my presentation with another 14-year-old female who was referred to the neurosurgery department for a pituitary macroadenoma. The 14-year-old female had a height of 124 centimeters, which was much less than the third percentile for her age. The patient did not have well-developed secondary sexual characteristics and had primary amenorrhea, which was the primary concern of her parents. That's why the parents took this child to the general physician. Now, the general physician thought that this short stature, along with absence of secondary sexual characteristics or incompleteness in the secondary sexual characteristics, and primary amenorrhea, might be due to some problems associated with the pituitary gland. So what he did was, he directly went for an MR imaging. And on MR imaging, the physician found, yes, there is a pituitary macroadenoma. And if you see the reporting also, we find that the impression in the radiological MR impression was a pituitary macroadenoma with minimal suprasellar and without any parasellar extension. So we need to understand that this is a common scenario in a adolescent female presenting with short stature, delayed puberty, or absence of secondary sexual characteristics after the age of 11, 12. In these scenarios, the patient might be might become a concern for the parents, and they usually take them to the general physician. And if in this case an MRI is asked for, this is what we find. Now, we need to understand what is the problem with this. If you see the thyroid profile of the same female, what we find that the TSH is 190. Now, we need to understand that primary hypothyroidism will have more or less the same clinical features of a non-functional pituitary adenoma, in particularly in the adolescent females and also in the adolescent males. So if we go for a radiological evaluation, MR evaluation, prior to a hormonal evaluation, there is good chance that we mistake the cases, we lose the cases, and what happens is that we refer the patients to a neurosurgeon because the MR imaging is showing a pituitary macroadenoma, which actually is not a pituitary macroadenoma, it is just a thyrotroph hyperplasia. We all know that when there is untreated or inappropriately treated hypothyroidism, the pituitary needs to produce a large amount of TSH, and for that, the thyrotrophs undergo hyperplasia, and they mimic a pituitary tumor. So here lies the problem. So what happened to this female when the endocrinological evaluation was sorted? The endocrinologist gave 6 months of levothyroxine supplementation. And what we find? Yes, from 124 centimeters within 6 months, the height increased to 130.5 centimeters. The child had onset of menarche within 2 months of therapy. So what happened to the MR image? This was the pre-treatment scan, and after 6 months, when the MR was repeated, there was no macroadenoma. So what it depicted, it is just a pubertal hyperplasia of the pituitary. Macroadenoma is gone because there was no macroadenoma. It was just a thyrotroph hyperplasia. I will show you a second scan again. But before that, I will show that yes, this type of presentations were common, and demonstrable regression of a pituitary mass in a case of primary hypothyroidism is depicted in the literature, even after a week of acute hormone therapy. So this is the second MR imaging where you will find a similar picture in a cases of untreated primary hypothyroidism. And you will find that in this coronal imaging, the same type of homogeneous enlargement, not only homogeneous, it will be homogeneous symmetric enlargement of the pituitary in a case of untreated hypothyroidism, which mimics a pituitary macroadenoma. So these were the two cases which we found, and in both of these patients, after treatment with levothyroxine supplementation at 6 months, there was no pituitary macroadenoma, and there was total normalization of the pituitary architecture. This is the third MRI. Actually, this is the first MRI which we showed in our introductory slide, where unfortunately this 24-year-old female was operated because a hormonal evaluation an endocrinological evaluation was not performed or was perhaps overlooked. We moved into the literature to find out these type of more cases. We went into and found that there was a similarity of all the cases in the literature, the MR images of all the cases in the literature of untreated or inappropriately treated primary hypothyroidism with our cases. And what was that? It was the symmetric midline homogeneous enlargement of the pituitary in cases of untreated primary hypothyroidism. So what all these images show, what it looks similar to something, might be a dome. So a dome-shaped pituitary enlargement, which may be said as the dome sign, if found in the radiological evaluation of such a patient, young patient, dome sign, a homogeneous symmetrical enlargement, we can say that this patient needs further endocrinological hormonal evaluation prior to any neurosurgical intervention. And what is the reason for this symmetrical midline dome-shaped enlargement in cases of primary hypothyroidism? It was wonderfully illustrated by Ben Shlomo in this anatomical illustration of the pituitary, where it was found that the thyrotrophs are present in the midline anteriorly, and when there will be primary hypothyroidism, these thyrotrophs have to enlarge. And if they enlarge, how will they enlarge? They will enlarge from the midline and in a symmetric pattern. So that is the reason why this dome-shaped enlargement basically occurs. So in our article published in 2020, we described this dome sign. Now, when we describe a sign, we need to understand what is the relevance, what is the clinical relevance of the sign. There may be a lot of signs, but what is the clinical relevance of the sign in day-to-day clinical practice? Is it a problem only in the developing countries or underdeveloped countries, or it is a problem also in developed countries, that patients who present with such features are directly moved into radiological imaging, found to have a pituitary SOL, directly operated? So what is the relevance? The relevance was beautifully illustrated in this 2024 article, where Anna Rox and Valentina Gasco, they went into a comprehensive review of literature of these cases of long-standing primary hypothyroidism. And what did they find? That they found that a significant number of cases of this primary hypothyroidism were in fact operated. They underwent neurosurgical intervention, either with or without concomitant levothyroxine therapy. So this is important, that if we see a dome sign, forget the patient has not been done the laboratory hormonal evaluation. Only a radiology, MR imaging is present and you find the dome sign. Please think twice before surgical intervention. Reevaluate, see the hormonal workup, see if there is long-standing untreated hypothyroidism or probably inappropriately treated hypothyroidism. And only then, if you are rest assured that this is indeed a non-functional pituitary macroadenoma, and which can cause optic chiasmal compression, only then we can go for a surgery. So coming back to the first case, introductory case, the 24-year-old female whom we thought was basically a lucky girl because only she did not continue with multiple pituitary hormone deficiencies, might have been a bit luckier if these hormonal profiles were properly evaluated and supplemented. There would have been no reason why this patient needed surgery. So, in a nutshell, we need to understand that most of the pituitary incidentalomas might need watchful observation and follow-up. A thorough endocrinological workup is mandatory prior to neurosurgical referral, and a homogeneous, symmetric dome-shaped pituitary enlargement, which we call it as the dome sign, might indicate untreated or inappropriately treated primary hypothyroidism. So, thank you. Thank you, everybody, for letting me share my experience as far as this dome sign is concerned.